Let us move on to the next topic, which is skin cancers. There are mainly two types: basal cell carcinoma, which is more common on the upper lip, and squamous cell carcinoma, which is more common on the lower lip. Sun exposure strongly predisposes to skin cancers. Let us see one by one. Basal cell carcinoma. It is most common skin cancer. It is found in sun-exposed areas of body, which is face. It is locally invasive but rarely metastasizes. Waxy, pink, pearly nodules, commonly with telangiectasias, rolled borders, and central crusting or ulcerations are seen. These are the buzzwords: telangiectasias, rolled borders, and central crusting or ulceration. Basal cell carcinoma also appear as non-healing ulcers with infiltrating growth or as a scaling plaque. Superficial basal cell carcinoma and basal cell tumors have palisading aligned nuclei. Let us see images. This is basal cell carcinoma, rolled margins, palisading nuclei. Next is squamous cell carcinoma. It is the second most common skin cancer. It is associated with immunosuppression, chronic non-healing wounds, and occasionally arsenic exposure. Marjolines ulcer. It is the squamous cell carcinoma arising in chronic wounds or scars, usually develops more than 20 years after insult. Commonly appears on the face. This is squamous cell carcinoma. Lower lip, ears, and hands. Locally invasive may spread to lymph nodes and will rarely metastasize. Ulcerative red lesions and in histopathology, keratin pearls are seen. Now, next important skin cancer is melanoma. It is common tumor with significant risk of metastasis. This both does not metastasize, but this does. Here A100 is the tumor marker. It is associated with dysplastic nevi. People with lighter skin tones are at higher risk. Depth of tumor is described by Breslau's thickness. It correlates with risk of metastasis. Breslau's thickness includes ABCDE, which is asymmetry, border irregularity, color variation, diameter more than 6 mm, and evolution over time. At least 4 different types of melanoma including one is superficial spreading, which is most common type. This is the type. Second is nodular. Third is lentigo maligna and acral lentiginous, which is highest prevalence in people with darker skin tones. This often driven by activating mutations in BRAF kinase. Primary treatment is excision with appropriately wide margins, and advanced melanoma also treated with immunotherapy like ipilimumab and or BRAF inhibitors like vemurafenib. Let's see one point. Clark's system is based on the layer of the skin which is invaded by melanoma. Breslow thickness has largely supplanted Clark's as it is a more accurate method of predicting prognosis. Malignant melanoma, which fills the papillary dermis, impinging on the reticular dermis but not invading, is classified as Clark's level 3. Let's see this malignant melanoma. Both Breslow and Clark system are used to stage melanoma on the basis of depth of invasion. Classification. Level 1 is epidermis, level 2 is invades papillary dermis but doesn't feel it. Grade 3 is fills papillary dermis, impinging on reticular dermis but not invading, and grade level 4 is invades reticular dermis. Whereas Breslow's classification includes stage 1 to 3. First, in stage 1, the depth is less than 0.75 mm. In stage 2, it is between 0.76 mm to 1.5 mm. In stage 3, it is 1.5 to 4 mm. And in stage 4, it is more than 4 mm.